Okay, hi everybody. This is compliance training for behavioral health practice. My name is Jennifer Yturriondobeitia, and I am with Cornerstone Whole Healthcare Organization. We are going to learn about billing and coding compliance with clinical documentation. My job really is to scare you, but at the same time give you solutions to some of your compliance questions or things that you may not really have considered in your practice around compliance. So I'm asking that everyone do a survey and do the test from the chat box. I see that Denise, you just joined us, so just go into the chat box, do the survey, download the compliance quiz, and it's an open book quiz. All right. So we have a good number of people. I'm really happy to see everybody. Apparently everyone wants to have this exciting discussion about compliance, which no one wants to have. Hopefully I can, I don't know if I'll make it any more exciting, but at least we'll have an ability to have a dialogue around compliance. So one of the things is I used a lot of the compliance materials that you're going to see through the National Council. I've been trained through several of the National Council trainings and also with corporate compliance through I think it's a National Compliance Organization. Thanks, Megan. So majority of the slides that you're going to see, I just want to make sure you know that I didn't make these up. This was created by a contractor through National Council with this Adam Falcone and the Feldman Tucker Leifer and Fidel organization. My job really today is just, it's going to provoke a lot of anxiety about maybe what you are or are not doing around compliance. I just want you to be well educated, and I also want you to know that there's resources on how to mitigate risk. So this first module is really discussing what is compliance, what is considered potential violation of compliance, and that borders on fraud. So hopefully, I'm not going to give you too much anxiety, but just know that this is going to probably give you a lot of thought about what you're currently doing in practice. So the key compliance implications of healthcare reform. So I want you to think about when you're looking at compliance, there's this circular process of compliance. And what you're going to notice is that this OIG, or Office of Inspector General, which I think is on the test, it's the enforcement authority. You're going to have mandatory compliance programs, whether you're in one independent practitioner or whether you are working in a clinic or an organization. You're going to have mandatory return overpayments. You're going to have high risk of false liability act liability understanding, and you're going to need to understand the increased program integrity activities that you're going to need. So if you remember anything after this training, just know that you have to have a compliance program. And I will give you these slides, so just don't worry about taking all these copious notes. You will have this slide, and I will also give out the link to this video as well. All right, so mandatory compliance program. Under the Affordable Care Act, as a condition of enrollment in Medicare and Medicaid and CHIP providers, you must have a compliance program. And this was required for expansion of Medicaid under health law, reform law. So core components of compliance programs to be established by the Secretary of HHS in consultation with OIG. Again, Office of Inspector General. And you need to have a clear, a specific policy specific to a particular industry or category or supplier. So you have to have a compliance program that's specific to mental health or behavioral health services. And what this compliance program also is effective after HHS issues these regulations. So long and the short of it, all this means is you have to have a compliance program that fits your business, which is mental health, behavioral health. And you have to understand what kind of governance that you are bound by. And in the mental health arena, when you're integrating behavioral health in medical practice doesn't seem to understand a couple of things. And maybe they do, but when I first started integrating in behavioral health into primary care, they didn't understand that mental health was governed by basically three policies. One is federal, one is state, and then the other is your internal policies. And the rule of thumb is that whichever policy is the most restrictive, and if you ever get audited, they will audit the most restrictive policy. Most people don't realize that you are governed with these three different entities and they don't always talk. So sometimes the state has more restrictive regulations than federal, and federal sometimes have more restrictive than state, and they don't always match. So someone has to be always aware that there's the federal and state policies that you have to meet. And that's why I started doing these compliance program trainings, because a lot of people didn't understand that there was that you had three masters. I believe this is on your test. Federal, state, and you might have a managed care organization, and then your internal policy. So in Idaho, right, you have the federal, you have the state, then you have Optum, and then you have your own internal policy. Okay, and false claims liability, what is that? If a provider has a compliance program that does not meet the standards established by HHS, or like the four entities I just talked about, right? Federal, state, your managed care organization, and your internal policies. If you fail to meet them, those are potential false claims liability. So all this means is, in regards to the mandatory return of overpayment, is that if you get overpaid or if you overcharged the federal government, I'm just going to use Medicaid as an example. If you overcharge Medicaid and you know about it, or if you didn't know about it but you found out later, even if you don't know about it, you are obligated to figure out that you did an overpayment, and you are obligated to pay that back in X amount of days, which is 60 days of identification. So if you do not return overpayment, bad things happen to you in regards to, once it's found, there's going to be a per unit per encounter payback interest that you're gonna have to pay back, up to sometimes $11,000 per encounter. So if you had a overpayment that maybe you knew about, maybe you didn't know about, but whoever, the state or federal, audited you, and it was, let's say, 12 months ago, basically for every day that it is not paid back, you're going to owe the federal government X amount of dollars in addition to what you need to overpay them, what you were overpaid. So it's really important that when you have a compliance program, that you're monitoring for potential overpayments. So must have reason for the overpayment in writing, and you need to, and overpayment is defined as funds that a person or entity receives or retains under Medicare or Medicaid to which the person or entity, after applicable reconciliation, is not entitled. So long and short of it, you were overpaid because you either overbilled or they overpaid you. And if you do not pay that back, you have very harsh fines that's going to come back to you. So higher risk of False Claims Act. So the False Claims Act, which is FCA, that's their acronym. This is the statute. If you really want to bore down to it, if you have a lot of time to do that, great. If you don't, there it is. What that means, FCA forbids knowingly presenting or causing the presentation of false claim for reimbursement, making, using, or causing to be made or used a false record or statement material to a false or fraudulent claim, repaying less than what is owed to the government, knowingly and improperly avoiding or decreasing an obligation to pay the government, and conspiring to defraud. This particular slide was given to me back in the early 2000s, maybe 2010. Around 2015, OIG changed their definition of who's at fault. So with the False Claims Act, so do you guys remember AIG? They got in trouble for fraudulent activities, and the president or the CEO said, "I don't know who this person is that did that. I'm way too high up in the ladder to know who works in my company." And basically he said, "I'm at no fault." And so in 2015, what they did was they changed that. So basically, me as the CEO of Cornerstone, if somebody does something fraudulent, down to like my front office, to someone that I don't interact with, let's say the janitor, and they did a fraudulent claim, it does not matter. Every rung of your hierarchy is responsible, and so you cannot claim that you didn't know who did that fraudulent claim because you're too high up on the chain and you don't know everybody. It doesn't matter. You as the authorizing authority, or you have legal and fiscal responsibility of the organization to the board and up through the board, you will all be considered violating the False Claims Act now after the 2015 law had changed. So high risk of False Claims Act, again, this is the definition of what a claim is and what knowingly means. Knowingly, again, is actual awareness of falsity, deliberate ignorance of the truth or falsity, or reckless disregard or truth of falsity. Sorry, this is all legalese stuff. I also want you to know that when you look at false claims, I'm trying to get to a slide right here. When you look at false claims, you have to look at them in sort of this bucket. There was a kind of a error that was made unknowingly. You created waste, which was inefficient, or you were knowingly abusing, bending the rules, or you knowingly, intentionally were deceiving. So what's unfortunate is, even though you made an error, you didn't catch it, you had poor compliance monitoring, you still have the same consequence if that error is found, and you don't have mitigating policies of why you missed that. So just be aware you can fall into even this unknowing as fraudulent as well. Okay, I'm gonna take a breath and just kind of like, how's everyone doing right now? You can give me a thumbs up, thumbs down, or, okay.
Doing good.
Okay. All right. So procedures with False Claims Act, right? Attorney General may bring on an action. So qui tam, be familiar with that wording. Qui tam means just whistleblower, okay? And qui tam is, can be a private person that can bring an action in the name of the government. You must submit a formal complaint to the court with written disclosure of all material evidence. Government has 60 days to review and may request extensions, and government may decide whether or not if they're going to intervene. The other thing about the qui tam lawsuits or whistleblower is that if you bring the suit to the government and they decide to go for it down here, they said, okay, you have a legitimate case, we're going to actually investigate. And if they win, the whistleblower has the ability to receive 15 to 25% of what they collect. So if you think of AIG, the amount of money that they probably reclaim from AIG, if you were the whistleblower, you have the potential of actually getting 15 to 25% of what they collected. Now, let's say you were a whistleblower and the government decided not to take action, but you pursued and went for it anyway. And it was found legitimate and the government did collect on it. You actually, as the whistleblower, have the ability to receive 25 to 30% of what they collect. Not to say I want everyone to be a whistleblower for the sake of collecting money, but the False Claims Act has built these things in to either kind of incentivize whistleblowers and also give some protections around whistleblowers as well. So again, with qui tam, you have a protection around retaliation, and also about this public disclosure. What's interesting is you can't take information like you read off the newspaper or got off of social media and go, hey, government, I'm turning this in. You have to be part of that process of a direct relationship with the company of record, how you found out. It can't be just something that you researched and then you're going to give to the government. So then basically this public disclosure bar. Public record versus original source. Okay. One second here. I see some new people have come in. If you're new, please download the compliance quiz, and also please take the survey, pre-post survey that I just put on the chat box. Also, there's the FERA, which is the Fraud Enforcement and Recovery Act. That was enacted back in 2009, and it was amended. It's an amended federal civil False Claims Act. And so it expanded the whistleblower protections and expanded the FCA how it applies even if the false claim was not submitted directly to the federal government. And it codified liability for knowingly avoiding an obligation to repay the federal government or reverse false claims. I don't expect that you guys to remember all of these details. Just know that there is a fraud enforcement and recovery organization, and they are organized to look for companies that are creating fraud. So Again, more conversations about QUITAM, the difference between the original source and public disclosure, and knowing retention of overpayment. So the FCA violations results from knowingly and improperly avoiding or decreasing a payment obligation. So health reform law makes knowingly retention of overpayment beyond a due date, which rule of thumb is like 60 days, an obligation under the FCA. And these are the penalties. The penalties can be up to $11,000 per claim, and sometimes 3 times the amount of the overpayment. So if you didn't catch the overpayment for X amount of time, that claim can actually, it not only have $11,000 per claim, but they could also impose interest for all the time that you have not paid for it. So just be aware, have a good compliance program that you're monitoring and reviewing for data integrity, making sure that you're monitoring risk. All right, increase program integrity activities. So I apologize, this is a really dry section, so I'm going to try to get through it as fast as possible, unless you need me to slow down. So the HCFAC, or the Federal Healthcare Fraud and Abuse Control Program, it established as a requirement under HIPAA to combat fraud committed against all health plans, both private and public. And it's jointly directed by the Attorney General and Health and Human Services Office of Inspector General. And it's designated to the state, federal, state, and local law enforcement activities with respect to healthcare fraud and abuse. So in 2011, the HCFAC won judgments of negotiating over $4.1 billion. So they are making money. So what they found is that developing these fraud control units, they've been able to actually go back through retrospectively claims and going to the organizations to find if they've got supportive evidence of their claims. And basically what they're finding is that they're able to recruit billions of dollars from companies that have been fraudulently billing, and maybe knowingly or unknowingly billing for services fraudulently. So basically, these control units, especially if they're using racks, which are, they basically look for CPAs, not clinicians, to go in and look for mistakes. So they get paid for when they find a mistake. They don't get paid for if you're doing great. They are paid to find mistakes. So U.S. Attorney offices opened over 1,000 criminal healthcare fraud investigations involving 2,500 potential defendants, 743 defendants convicted. And again, this has led up to $4.1 billion. It's a great money-making scheme for these guys. So they have actually recovered since 1997. This was back in 2011, over $20 billion. And they had projected even more for even to now, how much they were going to recover. So additional funding, so basically these control units, they're making money for the federal government, reclaiming. So the Affordable Care Act appropriated additional $10 million per year from 2011 to 2020. And Reconciliation Act appropriated an additional $250 million to the account for 2011 to 2016. So this is very profitable for the federal government to go back and pay for people to review your claims to see if there's any fraudulent behavior. as you can see, they're reclaiming quite a bit back. So there's the Medicaid fraud control units. They can be at the state and federal level, and their purpose is finding and reporting Medicaid fraud. Also investigate and prosecute patient abuse and neglect in healthcare facilities. And the MFCUs are state agencies that must be separate and distinct entities from the state Medicaid agencies and funded through the Medicaid grants to states. 49 states and the District of Columbia have established MFCUs. If you want to know more about them, here's some more information, but they've recovered over $1.8 billion in fines, civil settlements, and penalties. And to even scare you a little bit more, it's a huge return on investment to have these fraud units. They've reclaimed, as you can see, billions of dollars from just one state. The Medicaid Integrity Program, or the Medicaid Integrity, MIP, sorry, in 2006, it was created by Congress. CMS has two broad responsibilities under the Medicaid Integrity Program, and that's to hire contractors to review Medicaid provider activities, audit claims, identify overpayments, and educate providers and others on Medicaid program integrity issues, and to provide effective support and assistance to states in their efforts to combat Medicaid fraud and abuse. So I'm going to ask a question to the group. If you were to look for a company or look for guidelines or Google what is considered a compliant program or compliant, not program, but the things that you're going to be audited for in a Medicaid audit, or how do you prepare, how do you educate? If you guys could either unmute or in the chat box, if you were to Google it or look for it yourself, do you think you can find it?
No.
No, I don't.
Well, I'm confused by your question, Jen. Can you, what am I looking for?
So the stuff I'm teaching you right now, the intricacies and details about auditing, what's considered fraudulent, what are the things that you should be aware of for mental health services for audits to get prepared? Could you find it? Could you Google it? Is there a guidebook out there?
I don't know if there's a guidebook, but I know that I use a lot of the CMS rules and regs when it comes to that stuff and looking for what's billable and what's not billable.
So CMS has some overarching guidelines, but until you have been audited by the state or the feds, you will actually not know the details of how you are going to be penalized. It's not well advertised and you can't really find it. The reason why we know this is the company I work for did get slapped with an audit and had to repay over close to $500,000 back. That's when we found out what we were supposed to do, but it's not well advertised on what is it exactly you need to do for especially around mental health services, what's considered compliant. There's a lot of people, I think there's a lot of different interpretations, and how do you really understand the policies? Megan, you're unmuted. Did you want to say something?
Yeah, I was also going to say, I think that audits evolve as they begin. And so every audit is a little bit different as the auditors or the auditing entity discovers practices that may be common in your agency, and then they continue to focus in on certain areas. So that was kind of my comment. Every audit is a little bit different.
Yeah, and just what Megan said, interpretation, depending on your auditor, is also interesting. So if you don't have a strong compliance program and how you justify what you do, they can put their own interpretation on it, and it might be even different auditor by auditor. So this is why it's really important to have your understanding of your compliance program and why you did what you did, because it will vary, because how people interpret the policy can be very different. And Crystal, yeah, I mean, there are compliance manuals out there. They're going to give you kind of general overviews, but I'm going to show you how we found out we violated some of these rules, and we didn't even know about it, and which made us be more diligent about how we were doing trainings and how we were training people around compliance. But thank you for saying that. There are some guidelines, but unfortunately they're not detailed enough, and sometimes they're not detailed enough for mental health. This is just a kind of org chart of how they do Medicaid integrity. And the thing about the recovery, the RACs, right? I was telling you about the RACs. RACs are independent auditors, and they're just looking for what's in your record, not what they're going to interpret as what should be in the record. So if it's not in there, they're getting paid for all the mistakes they find. So they are very aggressive about finding mistakes in your record. The healthcare reform law expanded RAC programs to cover Medicare also, Part A, Part B, and C and D, and Medicaid. And they are predicted to recover over $2 billion over the next 5 years. I'm pretty sure now it's 2020, it's quite a bit more than that. And I don't know about you guys, I hear every so often throughout the year how someone got charged with fraud within the healthcare system, within the mental health system. So this is live and active. Again, if you want to know more about the RACs, that was a final issue on September 2011. The purpose was to correct payment errors, and RACs must report potential fraud to the state, which must refer the activities to the appropriate authorities, and payments must be made to the RACs on a contingency basis. Again, they don't get paid if they don't find mistakes. They get paid when they do. Again, more about RACs. I don't think you guys really want to know all that. I mean, if you want more details of the RACs, here it is. And more information about the RACs. So again, I think this is on your test. OIG, Office of Inspector General. So under the Civil Monetaries law, which is the OIG may assess penalties for, right? False and fraudulent conduct related to health care programs or beneficiaries, which include submission of claims that are false or fraudulent, provided by someone who has been excluded from participation in federal healthcare programs and prohibited by anti-kickback statutes. So that part right here called excluded participation. So if you Googled OIG exclusionary list, there you will pop up a website where you can put your name in, or your employees, or anyone you work with, and you can see if they're on this list. If they're on this exclusionary list, they are prohibited to see and bill Medicaid, Medicare, or other federal programs. So if you have someone in your employment, or you know of a colleague that's on this list and they are billing away and seeing Medicaid, Medicare, or federal government programs, that is immediate payback. They are not supposed to do that. So your company should be checking the OIE exclusionary list at a minimum once a year to ensure that their people are not on that list. How you can get on the list is, the obvious one is if you got caught with fraud, but you can also get caught on there if you have been practicing without a license, or you've been practicing with an expired license, or you're over your scope. So like, for instance, you're a nurse practitioner and you went over your scope and you're practicing like an MD. The other is if you have defaulted on your federal loans, you will be on this list. So you should check the OIG exclusionary list just randomly, just to see if you're on the list, and figure out if you are and you don't know why you're on it. You need to immediately start mitigating why you're on that list. And if you have employees, you need to be checking your employees at a minimum to see if they're on the exclusionary list. And if you have billed for any services by these people, you need to report that to the federal government and pay back anything that they have billed for. Okay. OIG may also assess penalties up to $10,000 for each item or service falsely claimed, and up to 3 times the amount falsely claimed. They can also assess up to $50,000 for each kickback violation or anti-kickback statutes, and up to 3 times the amount improperly claimed. So they can seek to exclude the provider from participation in federal and state healthcare programs, which that means you will be on the exclusionary list. I believe that is on your test. Okay. Their activities, the OIG activities. So before I get that, go to here, there's a confusion around CMS and them being kind of this authority body. How you need to think of CMS and OIG is the enforcement body. They have the authority through the Department of Justice. They're the ones that can file criminal charges, and actually, they're the ones that can actually put you in jail or charge fines to you. CMS, you have to think of them as more of a guideline for OIG. So even though they're not the enforcement authority, they're actually the guideline that OIG uses for enforcement. Again, a lot of money they're reclaiming back, a lot of prosecutions and settlements, and they even have a hotline to call them in. And they've received more than, I'm pretty sure it's in the millions now in regards to the hotline calls. The health reform law authorizes OIG to impose CPMs when a provider fails to report overpayment, orders or prescribes overbills, right? Or prescribes or a medical or other items of service during a period which the provider was excluded, right? So they were on the exclusionary list. If the provider knows or should have known that the claim for such medical or other item services will be made, and then knowingly makes false statements, omissions, or misrepresentation, and fails to grant OIG timely access to their documents. So if they say they want it, you have to give it to them. When I've gone through the compliance trainings, I had heard stories where the feds came up with, in black sedans with copiers, went to the organization and copied files, and then they came back to the organization and said, this is how much you owe back to the federal government. In the early 2000s, there were a lot more mental health organizations being actually pursued and actually went out of business because of this new enforcement process. Again, false claims penalties up to $50,000 to 3 times the amount that you were overpaid. The RCO, so under the responsible corporate officer doctrine, it can be found, individual corporate officers can be found guilty or of violating a variety of federal laws without exhibiting unlawful intent. Again, this is where I was saying, whether you're the highest man or woman on your organizational chain, you are still responsible for anyone below you that has committed fraud. And the RCO doctrine, the government only needs to prove that the executive did these 3 things: held a position of responsibility and had the ability to prevent the violation and failed to prevent the violation. This was a 3-day workshop. On this presentation, there was actually 3 decks. And so I've narrowed this down to less than a half a deck of what they gave me. So I'm really abbreviating this. So the key compliance audits, if you think of anything other than like, yes, the government's coming out to get me, the key compliance audit, I want you to remember these things the most. If you take anything away from today, I want you to remember these things. The things that's going to get caught on an audit are unlicensed or lapsed licensed practitioners. Also, mid-levels exceeding the scope of their license, no progress notes or treatment plans in the medical record, missing signatures on progress notes or treatment plans, services rendered do not match the treatment plan, and we're going to go through this stuff in detail. Time of service overlaps with other services rendered to the same patient by a different practitioner. So that means at 1 o'clock on September 1, I saw John Smith, and then I did a claim for that time. At the same time, Denise was in the meeting with me as well, and she documents that she saw John Smith at 1 o'clock on September 1, but she uses a different code. That's called double dipping because the government does not see that this person can occupy 2 spaces with 2 services at the same time. So making sure that there's no overlap of practitioners and time frame with the same patient. Start and end time sessions are not recorded. So in the medical field, they use a lot of they use E&M coding. They don't necessarily, they just need to have a start time, but not a start and end time. Well, in our services with Medicaid and Medicare, we have to have a start and end time. And improper coding or billing, and it could be untimely billing as well. Services not billable due to the practitioner type. Employed or contractor is an excluded individual, meaning on the OIG exclusionary list, and there was a violation of anti-kickback statutes. So take a picture of this, whatever you need to do, and you'll have this PowerPoint slide, but these are probably the most key compliance audit areas that you need to be aware of. Okay, I'm going to take a breath. Any questions, any concerns, things that you're encountering with the information that I've presented so far? You can unmute. Can you give me a thumbs up, thumbs down, somebody? Okay, thank you.
I've just got a quick question. This is Anne, and this was a comment that you made earlier on, just with regards to maybe the dissonance or the lack of understanding from medical arenas as far as the, you know, what is necessary for mental health services. Has that always been the case, or is that you know, why does that seem to be so much of a confusion for these medical environments to understand or to know about mental health services?
Very, very, very good question, Anne. What I found is that I'll give you an example with like St. Luke's. When St. Luke's first started a specialty mental health in their system, which was around 2012, and then I was hired in 2013. The people that had started the mental health program, their comment to me was, we just thought it was the same as medical. We thought the regulations that you guys have is exactly the same regulations that a medical provider would have. So they're just really, they didn't know that there is this whole set of, you know, regulations that are specifically governed to us as mental health and behavioral health practitioners. And so I would say that they thought they knew, but they didn't understand that we are governed by different regulations. And it was helpful when I was able to talk to the coding and billing department to say, here are the regulations. There's some commonalities of compliance programs that you have to have in place, but this is how our claims are evaluated in an audit. And it was very different than the way the medical practitioners were audited, because again, they're governed by different regulatory body than we are. Does that make sense?
Yes, it does. So it sounds like, again, for individuals who maybe are just starting programs or integrating behavioral health or expanding their services, is to make sure that there's also good communication and understanding with the coding and billing division.
Yeah. Megan, can you unmute? And I like what you said there. Can you sort of expand on that?
Yeah, sure. You know, in behavioral health, we use more person-centered planning when approaching treatment for behavioral health disorders. With regard to, you know, a CPT code in medical, there's you don't really ask an opinion on how to cast an arm. And I think that that's a fundamental difference that the different regulations for behavioral health address, that's often overlooked in medical when approaching it from a medical perspective.
Thanks, Megan. Do you guys have any comments or concerns, or maybe you've ran across this in practice? So I need a bit of a bio break, so I bet everyone else does too. Anne, did you have a comment?
No, sorry.
Okay. Let's take 5 minutes, take a bit of a breather, and then come back at 10, well, a little more than 5 minutes. Let's come back at 10:05, and we'll then get started a little bit more on this 3 slides, and then I'm going to get into kind of compliance in practice, and that'll describe more of the things that we talked about. You know, that was all legalese stuff that's up on the top, and this the next steps, the next hour, we're going to cover more on the practice-based things. Does that work good for everyone?
Sounds good. Thanks, Jen.
Okay, we'll meet at 10:05. Okay, So this hour is going to feel really fast, so just bear with me on, again, this is kind of a quick overview, and then the next 2-hour module will go into a little bit more in-depth conversations around how this applies to you in practice. The implementation recommendations for monitoring and auditing. So if anyone has worked with us on compliance with their integration program, we look at the way monitoring and auditing is done through your organization for your behavioral health practice. Sorry about that, a little froggy. Reasons for conducting these is to identify non-compliance through early detection, to tailor compliance programs, to initiate immediate corrective actions, and to measure compliance with corrective action plan, and then to improve clinical and non-clinical quality of care, and to comply with OIG's recommendation to compliance program guidance. Monitoring versus auditing. So an audit is an organization's retrospective assessment of compliance with applicable legal requirements. So an internal audit or self-audit is an organization's objective assessment performed by internal staff or at their direction, with results not reported to outside organization. It was really just a test to see how compliant you are, if there's any risks that you need to mitigate for quality assurance. Monitoring is a real-time assessment whether ongoing activities or operations are in compliance with applicable legal requirements. So this is something that when I was going through the compliance training, there's this weird magic number. I didn't know this unless I had gone through this training. If you do more than like 30 files per person or per organization for auditing, something about the magic number of 30, if you go over 30, it sort of falls into this weird monitoring process where you have to look at applicable legal requirements. So I always try to stay under 30 when I'm doing a audit for retrospective assessment. So this is just kind of a weird tidbit of information for you guys if you're ever interested in doing auditing, is there's this weird magic number with 30. And I don't know why, but that was what they told us when we were going through the compliance training. And key elements of risk assessment, and I believe this is on your test, is to identify risk areas, assess level of risk. You're going to rank risk areas and respond to risk. So these, you know, whether you're auditing or monitoring, this is what you're trying to do. And again, whether you're monitoring or auditing, you're going to be looking for these 4 buckets. If there's an error, there's waste, if there's abuse, or if there's fraud. Okay, before I move to this next section, do you guys have any questions, or do you have any questions up to now, or just even a random question if you have for me?
Not at this time, Jen.
Thank you. Okay. And this is on your test. So OIG is the enforcement authority of Department of Justice for fraud and abuse for Medicare and Medicaid. People get very confused between OIG, state Medicaid, and state licensing regulations. So when I was first auditing organizations in Idaho, I would go to the clinic and I would ask, where's your practice guideline. And they give me this binder, and I said, this is your state Medicaid requirements to be a vendor for Medicaid, but that is not a practice guideline. All this told me was you are following the state Medicaid guideline for getting licensed. What is your practice guideline? And so they didn't understand, because this was the first time they were doing mental health, that you have federal, state, and sometimes if you have an MCO, and then your internal policy that guides your practice. And they didn't have that. And so we worked on developing that over the next couple of years, so that if a auditor or a federal auditor comes to you and asks for a policy or a practice guideline, you should be able to give that to them. Most organizations I do stumble upon don't have that. And it's really important that you have a guideline that says you're doing this. If you don't, and you are knowingly or unknowingly doing things that violates the OIG regulations, it does not matter. You are still going to be hit with fines or charged. Okay, audit criteria. So one of the things is you need to make sure if you've been billing, they're actually beneficiaries of that insurance program. So I'm not billing Medicaid for somebody that maybe lost their Medicaid, but I keep billing away. And let's say the state didn't catch that, but they eventually catch you. If you don't pay that back, you're going to be in trouble. Same thing with Medicare. So, and also if you work in a state like Oregon that has what they call capitated payments, you get money up front to get paid. And if you're using that money to serve indigent patients, insurance patients, or someone who's on Medicare, you will get fined because you're basically using Medicaid dollars for non-Medicaid eligible patients. So make sure you're using money, you're not blending money, you're not using money that is not a member of that beneficiary. You have supportive documents. So all that means is if I provided a service, you have a receipt with detailed information that says I provided the service, it was it was medically necessary, and I have enough documentation to justify doing that service. Medical necessity. So if you guys can use a little thumbs up, thumbs down, or yes, no on the chat box thing. How many people were taught the definition of medical necessity in their training, in their practice? If you guys could give me a thumbs up, thumbs down, or a yes, no on there.
I was not trained on that. I'm on the phone. I had to switch over to the phone, Jen. This is Anne.
And you guys can unmute as well.
I wasn't taught medical necessity here, but Gen Y, you taught me medical necessity in my internship. So my answer is a little biased.
So we, as mental health clinicians, we're kind of at a handicap because the way we're trained, we're not trained like physicians, and psychologists are better at this medical practice definition. I don't know if they would tell you that they know how to tell it to me, but the way they document, they're all documenting to medical justification. But a lot of us as social workers and counselors and marriage and family therapists, this isn't in our training. And so if you didn't get this training outside of school, you may never get this training. So we're gonna talk about medical necessity. And all that means is this person has symptoms that needs services. And if you don't provide the service, this person's going to get worse. And a lot of people don't realize, like, they're not documenting to that. Like, why am I, as a practitioner, needing to charge for services for this symptom? And is it bad enough for me to be intervening? So we just have to give a statement that, yes, it's bad enough and it's within my scope and this person needs this level of care. Billing and coding practices. They're also going to be looking at how you are billing and does your documentation meet that billing code? And are you following the compliance applications of federal, state, and internal policies? And are you meeting third-party liability? And are you meeting provisions of service? So I actually have used this particular slide for 10, 15 years, and it still seems to be applicable with the exception of moving to electronic health record. So the top 10 mental health audit findings usually comes down to this. There is lack of documentation, including annual updates. So in the medical arena, if you're a practitioner, you just do episode of care. So when you document, it's an episode of care. So your 2 document styles are new patient visit, and then follow-up visits. But there's really no end date. It's just episodes of care. So every time you document after the initial, you basically, it's one note standing by itself. In the mental health arena, we don't have that luxury. We have to have this hierarchy of documents. And if we are billing Medicaid and Medicare, we have to have these annual updates on everything from the assessment and the treatment plans. The medical practitioners have something like that, but it's not to the extent that we have. And I think it's because we're considered sort of a soft science. Everything seems to be subjective because our patients can't pee in a cup and tell us that they're depressed or how depressed they are by measuring their labs. So we have to provide subjective information based on the patient's report and our clinical judgment. And because of that, we have the burden of documentation is very heavy on us. So that's why we have this huge documentation hierarchy process, right? You have to have an assessment, and then depending on if you're in a managed care organization, they're going to require you to have this huge mental health assessment requirement, and then you have to have this treatment plan that the patient has to sign. And I'm going to ask everyone in the group, you can text it in the chat box. How many payers require the patient to sign their treatment plan? And you can unmute yourself as well. How many payers require the patient to sign the treatment plan?
I thought it was just Medicaid.
Okay, Denise said all of them. Anne says Medicaid. Anyone else? Stephanie says 100%. Megan? So Medicaid is the only insurance program that requires the patient to sign the treatment plan. None of the other insurances require it. So we have this really awkward system when you're integrating in a medical that requires this patient signature on the treatment plan. 100%, everyone, all the insurance companies requires signed consent to treat in the file, but a signed treatment plan is only required by Medicaid. And you have to do it every year or as needed. or as needed when the treatment plan changes. So that's another burden on us to get the signature. So the other thing is we're usually missing progress notes that shows every service we did. And because you maybe got delayed on getting that progress note in, but you put the bill in. So you don't have a receipt for the service that you actually billed for. That'd be like paying the plumber for something that he couldn't describe what he did to you, what he did to your house or to your pipes or whatever you had him fix, right? And then there's no signed consent that this patient consent to see you. And that's the other thing that we have. We have this extra thing of consent from the patient that the physician, like if you're an LPC, you have another layer of consent that you're required to do with a patient because of your guild requiring that of LPCs. So we have these little intricacies depending on even our different practices about consent. And those are things that we have to help teach the primary care if we're integrating, that there's these nuances with our practice. The other common mistakes that we find in audits is that the treatment plan doesn't have a quantifiable amount and it doesn't show modality of delivery. So I'll give you an example. When I used to audit charts, I had this one practitioner, she put in provided IT on the progress note. That's all she had on there. I'm like, IT, so is that you were helping put cable in someone's office, or were you doing individual therapy? So as obvious to you guys, that is not a good claim. That claim should be audited and we should be returning money because I have no idea what she did. So I also didn't know how long she saw the person, and I also didn't know what the hell is individual therapy? Did she use CBT? Did she use DBT? Did she use motivational interview? What kind of modality did she use for the intervention? And she didn't also describe what she did in treatment either. So most common thing is I usually don't know the amount of time they were with the patient. So for instance, early on when we were doing audits, you would have one session per month. Is that a quantifiable amount?
I don't believe so. I think you're going to have to indicate that the time actually spent with the individual.
So you have to estimate how much you're going to have to provide treatment to this patient. So you will have to prescribe treatment, like medication. So just like a doctor would prescribe medications or prescribe a treatment, you have to say, I want you to do it for this much, this length of time for this duration. So 1 hour, twice a week for 12 months, 1 hour, twice a week for 6 months. So you are prescribing treatment with a modality. So think of that as your prescription pad for this patient. So I would say the treatment plan has been probably one of the most common errors on audits because you don't have a quantifiable amount and you're not using a system that the patient understands that, hey, I'm supposed to do this. I'm supposed to see you twice a month for 1 hour for 6 months so that they know how long this treatment's going to take for them to complete treatment. You would never see a doctor go, I want you to take this pill one session, one session. And you're like, what does that mean? They're going to say, I'd like you to take this pill with food at 12 o'clock twice a month for 30 days. Or twice a month, twice a week, twice a day for 30 days, right? They're going to be as exact as possible. And then they have to sort of tweak it because they don't know, they have to sort of take their best guess that this is the amount this patient's going to need based on gender, race, size, and age, and history of this patient, that medication is going to work for them. And then they meet with the patient and they have to adjust it because the meds are going to be very different every, potentially because of side effects or this person's own chemistry. So this is the same thing. We have to take our best guess in the frequency, length, and duration, and the type of service or type of intervention we're going to do with this patient. Do you guys have any questions about that?
I have a question, Jen, about the treatment plan.
Go for it.
So with the allowance of phone visits and telehealth, particularly the phone visits when oftentimes they're completed because someone doesn't have access to a computer or smartphone or tablet that would allow them to utilize software like DocuSign. How does that factor in given the recent pandemic in the guidelines?
The treatment plan or the?
Yeah, the signing of the treatment plan when you're providing telehealth, and do changes need to be made to the treatment plan in terms of
Delivery?
length and duration if, for instance, the person arrives 20 minutes late one time? I mean, how rigid is this? If we say an hour session and then someone arrives half an hour late, how do we handle that? And do we have to make accommodations in treatment planning, even for one-time occurrences such as that?
Very good question. I even have an answer for that. So we are people, right? We're unpredictable and we have situations that happen to us. Sometimes you're in an accident or you're sick or just different things. And so the treatment plan is, again, a best estimate based on the duration that you're going to be with this patient. So there's times where in 1 month, maybe they showed up once and then they were able to sort of make up for it the next month. As long as on an average, based on your duration, you stay within the amount. Does that make sense?
Yep, that makes sense.
Also, if you have those incidents where it's kind of a one-time, one-off deal that's slightly different than what you prescribed in the treatment, you just have to document that and document it where it's a standalone document. It's not like where you go, I did this. They normally, I usually am shooting for depression, but they came in because they were suicidal, let's say. And you had to use a different CPT code because you have to deal with what this patient is going through right now. You can do that. You just have to justify it on your document why you deviate from treatment and why you needed to do this on that one document. Don't go, please reference to this other document, blah, blah, blah. The auditor will never look for it. So just make sure that if you do have a one-off and you did something different with it and a whole different symptom, just write it, make sure it's justified. Now, if you keep doing that, let's say you do it 4 times, 5 times, and you didn't adjust the treatment plan, you basically set up a pattern that you violated your treatment plan. So if you're seeing that, you're noticing that you're doing this type of service more and more, you need to look at adjusting your assessment and treatment plan to incorporate this new service. Megan, do you want to unmute and sort of comment on your information here?
Yeah, I would just say that the assessment and treatment plan together can also document and communicate to auditors, or in each case, any factors that interfere with a client's engagement in that level of care that's recommended. And that just helps, I guess you would say, when, you know, someone can't stay engaged for 30 minutes in a session, even, or an hour in a session, really can only stay engaged in 30 minutes because of active symptoms, or because their ride shows up early. So it's just important to, I think that's important to also look at those individual factors and document those in the assessment and treatment plan. Barriers, or, you know, someone that's completely, someone that's really not willing to engage, maybe they're mandatory, they have mandated treatment, so they're just gonna check out basically. So I think that's something that you can, that helps with an auditor in understanding that as well.
Yeah, and it should be a fluid, this, you know, if we're really patient-centric, right? This should be fluid with the patient. Unfortunately, in the mental health arena, we have this huge burden of these large documents to update. And so, but, you know, especially in the integrated arena, our documentation is a little bit more abbreviated using health and behavior codes. But when you fall into the psychotherapy codes, and you're doing Medicaid, you have a larger burden of their required documentation for mental health assessment and treatment planning. But it should be really fluid. So Lynn, that was a really great question, because people do get stuck on this idea, like, how rigid is this? And it really should be based on what the patient presents with. And if you need to adjust the treatment plan, just understand that what you need to do, how to adjust it, and that if you do adjust the treatment plan, you got to get the patient's signature if it's Medicaid.
Thank you, Jen. And in regards to the telehealth or phone visit questions, what would you recommend to us in that regard? I mean, that's been a struggle for us. We mail documents and folks just don't mail them back.
Yeah.
And how would you recommend handling that?
The best thing to do in those cases where you can't, you know, where you have to send the documents to them, is write in your treatment plan, your progress note, that patient gave verbal consent, sent in the document for them to sign, just have not received documented signature. If you have something like that, where you can point to it saying, hey, I did try, this was a telehealth setting, they just didn't send it back to me. As long as you have that documented, you have justification that you have at least a verbal consent, and that you had been working towards getting their signature. If you don't have that and they audit, that's where you're going to find that you're going to have problems with the Medicaid.
Thanks, Jen.
Mm-hmm. That great question. Does anyone else have a question like that, or something else that was burning deep?
No, thank you for answering that, because we had just had that question like earlier in the week. So thanks.
You're welcome. Progress notes. So progress notes does not justify the therapeutic value of treatment. So you have a named activity rather than the therapy. So I'm going to give this example. So Stephanie and anyone that's gone through my compliance training have heard this. So if you had to audit files and you had to go through tons of progress notes, and if you know the formulary of hierarchy of documents, that you have to have this assessment and you have to have this treatment plan, and then the progress notes has to reflect everything, you know, based on the assessment and treatment plan. And I'll get this note where they're just talking about nothing. The patient showed up and they're talking. They're giving me this whole summary of nothing. And this is what it sounds like. Patient came in and we talked about milk. Patient came in and we talked about the color of milk. Patient came in and told me how they drank milk. And patient told me how they liked or disliked milk. Well, it doesn't mean anything to me because it has nothing that's related to what you assessed, what their symptoms are, and what you were supposed to do in treatment. So it really should reflect, like, patient, it was just Patient came in, you might give a little mental status, not a huge diatribe of mental status. You should be able to tell me that you provided individual therapy using DBT, and give me some sort of description that you actually did DBT with this patient and that there was this interaction between you and the patient. It doesn't have to be a huge multiple page description. It just needs to give me an overview and understanding, a receipt that this patient received individual therapy from X amount of time using DBT. This is what you did, not a blow by blow what happened in the therapy, but just enough for me to know that you actually did DBT. And it was helpful for the patient, or the patient felt that there was this interaction between you and the patient is giving you some sort of feedback in that. That way, I know you actually did treatment. Now, if you're a coding and billing person, they're not going to know the difference between DBT and CBT if they don't have a clinical background. What they're going to look for is you did a CPT code, did it meet medical necessity, and do you have enough documentation to support the amount of time you've been with this patient? And they're savvy enough to go into the DSM or the ICD to find out that CBT goes with that diagnosis. And they're gonna be able to determine if you meet that, that CPT code at a minimum. Now, if you have someone like me going through your notes, I'm gonna know exactly how that works from your assessment treatment plan and that CPT code, and if it met the level of care that you said you did for that patient. So you really need to be looking at it from the standpoint, if this gets audited, you need to think it's going to be me reviewing those documents. And a coding and billing person will really easily understand what you did in that note. And we need to help them because they're not clinicians, and mental health is a whole new set of rules for them that they're not going to remember. Also, progress notes does not reflect actual time spent face-to-face with the patient. So this is the common thing I see when I audit charts. You guys are, I say you guys, when I've audited charts, the clinicians are scheduled 8 to 9, 9 to 10, 10 to 11, 11 to 12, well, 11 to 12, 1 to 2, 2 to 3, 3 to 4, okay? So those are scheduled times. So what I see in a lot of notes is scheduled time, not face-to-face time. What happens when you use scheduled time? I got scheduled with someone from 1 to 2, and then 2 to 3. That 2 o'clock slot now looks like you billed for 2 people for a 2 o'clock slot, which is impossible. So if you're noticing that your billing system is set up on your schedule times, please stop doing that, because that will trigger an audit. And also it'll cause duplication of at least half of the people in your schedule. So be very careful that you're doing face-to-face time. That means make sure nothing overlaps, meaning in your note 101 to 153.
I have a question.
Yeah, go for it.
So say you're with the counseling patient and then they knock on your door to do a warm handoff and you step out for 2 minutes or a minute. Do you break down the time and say like this time to this time, and then when you got back in the room, or how would you document that?
Are you billing for the consultation?
No.
Okay, so what I would do there is, because you did have a break in there, what I would think about is how much time you spent with that patient, right? Because you're gonna have this weird face-to-face time, right? You
Yes.
come in and they've been sitting by themselves, and then they have, and then you leave and then you come back, right?
Mm-hmm. Yes.
So that one is it's a bit of a quandary when you're doing that billing. So if you're doing a psychotherapy one where you're not doing incident 2, but you're doing psychotherapy or H&B, right? What I would do is you're going to have to sort of contract your time so that maybe your start time starts a little bit later,
Okay.
so that it fits your time you actually spent with this patient. Just make sure nothing overlaps and you don't overbill.
Okay, that makes sense.
And you might need to just say, you know, why you did what you did, even though the patient was, you know, came in a little bit earlier, but you might need to set your start time a little bit later than when you actually saw the patient.
So it'd be okay if I just put a little note on like where the time is to say that I arranged that because I stepped out for a minute in between?
Yeah. Just as long as you have justification of why you did what you did, and you're not overbilling, that's the most important is that you're not overbilling, meaning you bill for something that you did not actually do with the patient. Time-wise, sorry. Did that answer your question, Maria?
Yes, because normally it'll just be a minute, like I'll step out, introduce myself, give them my business card, tell them to schedule on the way out. So it's normally like a minute or two that I'm out and then come right back.
Yeah. Like I said, adjust the time so it meets your time frame of how long you've seen the patient, and then also explain that on your note. Good question. So again, it needs to be face-to-face time. Make sure no patients overlap in your billing. And this is the other thing. If I consistently see in your record 1 o'clock to 1:45 for the same patient over and over again, statistically that is impossible. So make sure it's really face-to-face time versus you just billing exactly at 1 o'clock and 1:45. That will trigger an audit because statistically that is impossible to do with a patient every time. In Oregon, they have what they call qualified mental health associates, which are like case managers, skills trainers, or paraprofessionals or traditional health workers. And back in the day when we were audited, they were actually our highest risk in coding and billing because case managers were actually documenting like they were therapists, and it looked like they were outside of scope of practice. And so you have to really monitor any community health workers, caseworkers, skills trainers that are in your practice to make sure that they are within their, identified in the treatment plan, it's medically necessary, and that you as the mental health clinician, they're actually documenting and practicing under you as the on your treatment plan. So have a good compliance process in place where they're being monitored, and you do spot checks on those patients that have case managers so that you know that they're not working outside of scope. Excessive billing for particular codes. So this is another area that you have to be really careful. So for instance, there's a kind of what they would call standard of practice or standard of coding. So in the mental health arena, mental health assessments are usually like once a year. And there are times where you may need to do it more than once a year. But you have to show justification why you did a new mental health assessment. And this happens where you get a patient that comes in and they'll, you don't know them, you're getting to know who they are, and they're disclosing information. Like most people, when you first meet, you have to develop this trust, and so they're going to give you some information, and the more you know, the more they give you. And there are times where you have to adjust the treatment plan because what they originally came in with was completely different than what you finally realize that they have. And it completely changes the direction of your treatment plan that you prescribed. So that would be a justification to do another mental health assessment, because you have to kind of redo the whole thing, because you have to have a diagnostic, differential diagnosis, a new clinical formulation, and a new mental health a treatment plan that you prescribed, and then you're going to get them to sign. But as long as you have a good justification of why you updated the treatment plan and you build another mental health assessment, I mean, not treatment plan, a mental health assessment treatment plan, and why you build another mental health assessment within a year, just have good justification for it. So if you have a mental health assessment, but you had to update some kind of additional information, but it didn't really change the diagnosis, it didn't really change the treatment plan, you really should not be charging for another mental health assessment. You're just updating the assessment with newer information. So if I see assessments like, let's say more than 3, 4, that will trigger an audit, because that's considered kind of excessive billing, because you do get more money for an assessment. So if I see a lot of assessments done on one patient, you're going to get tagged on an audit, because I'll be looking at your chart going, what the hell's going on? The other kind of excessive billing are things like this, where where I had inherited a clinician, and they were doing treatment foster care, and he was billing, it was for mental health therapy per day. I want to say, like, he was billing like 5 hours of mental health therapy per day. There is a sweet spot for mental health therapy, individual therapy, and the standard of practice is usually like 1 hour once a week, right? And if you do more than that, like maybe twice a week, maybe even 3 times a week, that's only 3 hours a week. And you'd have to have really good justification for having this patient be seen for you for 3 hours a week. Well, this guy was billing 5 hours a day. It's considered excessive billing, because how many people do you know can tolerate 5 hours of therapy a day? Question to the group.
Nobody.
I think the only time you can see, I don't even think you could do an hourly, because there's a monthly billing rate for residential facilities and hospital facilities and stuff. It's like a daily rate or monthly rate depending, but hourly, that's just unheard of in my opinion.
Yeah.
Well, unless you're in DD services and you have a personal support worker that is working with you 5 hours every day, 5 days a week. That's a little different though.
Yeah, this was mental health therapy with a mental health clinician, 5 hours a day. And he was billing through the outpatient mental health clinic, not residential, not inpatient.
So I had a therapist try to tell me once who did that they were trying to keep them in a lower level of care to stabilize them in outpatient care, and so they were billing 5 hours a day of that. But I mean, no one can tolerate 5 hours of therapy like that, not even the therapist.
There's no evidence, right, that or research that supports that, and so that would definitely trigger an audit. So just be aware, make sure the amount of service you're providing to this patient matches this patient's severity of symptoms, and that you have a plan to basically where they're not going to need treatment. I mean, they're not meant to be in treatment forever. And that's the other thing where we should be working ourselves out of a job, not ensuring like we're going to be able to see patients for the rest of our lives. So those are things around excessive billing that you have to be really careful about. There's also things around underbilling. So let's say they can't afford services, so you underbill them. Well, you can't do that either, because you can't treat or charge a patient differently because their ability to pay. You have to actually treat them same across the board, whether they're indigent or if they have different types of insurance. You can't vary your payment schedule or whether you decide to pay or not to pay, charge them because they can't afford it. Now you can set a policy that for indigent patients to set them up on a fee schedule, but you still have to charge them exactly the same. So make sure like you're not overbilling and underbilling patients because of their ability to pay. Billing for services not provided for units that exceed the time spent with the patient. So Lynn kind of sort of asked this question, like, is this really rigid if I've got the set schedule, set amount of time? Brianne, can you unmute yourself for a second? Ask me this question.
Sure. Can you hear me?
Yep, we can hear you.
Okay. Well, I'm just thinking, I don't think it applies. I don't think we're a HRSA site, but I have been at them previously. And so one of the requirements in order to be that is that you have to offer a sliding fee scale where they pay based on income. And so how does that work? Because that's a federal requirement to be part of the program, but then it's going up against insurers that are going to be upset if you're charging differently.
Well, so you still charge the same, but you have set up a sliding fee scale for them based on their ability, on their income. So for indigent patients, that's what you would be setting that up, but you have to have a standard process that everyone would use.
Oh, okay. So as long as it's not like willy-nilly, like, oh, I like you, so I'm going to charge you 50. Right. Okay, gotcha. As long as it's like a standardized. Okay, that makes sense.
Great question, though. Great question.
So
okay.
Jen, I just have a comment on that. So that in a sense, everybody gets the same kind of bill, right? Like so for audit purpose, or not audit purposes, but when you say you're charging everyone the same, so they would all be, charged, let's say $10, but then if they qualify for a special program, what you'd actually say, this is the payment that we expect from you based on these other requirements. I mean, is that kind of what you're saying, is that when you say everybody gets billed the same, is kind of when they get their, I don't want to say bill of sale, but it all looks the same? Or how do you then apply these sliding scale fees to that same bill? Does that make sense?
That's how they pay. So for instance, whether when you walk through the door, whether you have insurance or you have different types of insurance, they're all charged the same amount for that service. And then with indigent patients, you develop a policy that says this is based on their income, this is what they can pay. And then Megan's comment here, right? The company would basically develop a process where you're saying you're going to write off X amount based on your policy. So she writes off through programs to reduce the actual cost to the patient through the services billed at the same rate. Does that make sense? So everyone gets billed the same rate. It's the way they pay is up to the patient.
Great. Thanks for that clarification on the process. I appreciate it.
That clarification is really important. So that was a great question as well. So billing for services not provided or for units that exceed the time spent. So I inherited a program where the social worker had been working in a substance use program, and unbeknownst to her, I became the executive director of this organization, and I started auditing charts. And I found that she had no documentation for the patients she was seeing, and they were all Medicaid. And I had to tell her that she had to get documents to support all the billing that she had done. This was like over almost a 2-year period. She refused, and I could not show in any way that we had any documents to support that these patients were seen. So I had to return all of the money that we had received from all those patients that she had seen, because I had no supporting documents for the services that were billed. And I also checked to make sure, in regards to the frequency and duration of the patient, that if, as I reviewed the records, did they exceed the amount that they were spending with the patient? And if so, I have to go back and basically return that money, because we were overpaid for something that was not agreed by the patient. I think I just talked about duplication of billing, making sure that you don't double dip, or you don't have two providers charging for the same patient at the same time and the same date. Or you as a practitioner looking like you're charging for 2 different patients at the same time at the same date. And billing for services over the phone that are not covered. So during this time, you could actually provide, in Oregon, you could actually provide some services over the phone, but they were very careful to tell you it can't be about, like, you can't charge for things like, hey, I'm calling to confirm my appointment, or about my refills. You have to actually do an intervention to actually bill for those services. And then oddly, the other biggest things were I was lacking dates and signatures on all of the documents. And so it's really, with the age of electronic health records, that has improved, but I still see missing signatures, because a lot of electronic health records don't have electronic signature capabilities. So just like Lynn said, we have to send it to the patient, or the patient has to come in and physically sign it, and then someone has to scan it and put it back into the electronic health record, which is a pain because it takes so many steps to get to there. So we're at the top of the hour, and I'm at the end of this particular section. We're going to set up a second module for 2 hours, around probably like this again, like on a Friday for 2 hours, and go to the next module where we're going to talk more deeply into the compliance documentation. Before we go, can you guys go back into your surveys and do the pre-test for me? I mean, the post-test for me. And was this helpful? You guys can unmute. Was this helpful? Do you need more? What can you guys give me a little bit of feedback?
I thought it was really helpful, Jen. I know we've covered some of this in my internship with you, but it's really great to hear again. And I learned something new, I think, each time we talk about compliance. So it's such a big topic that I really appreciated it.
You're a little biased.
This is true, I am.
I really appreciate the update in the context of healthcare reform and the increased compliance activities of the OIG in particular, Jen, so thank you.
Anyone else in the group?
I just want to say thank you.
Go ahead, Maria.
I have taken this before, and just like Stephanie said, it still gives me like that overwhelming feeling of like, wow, this is a lot. But I've learned things differently or understand them differently as I take it again. So thank you.
And I was just going to say something very similar of, I've done this, it was back when I was at St. Luke's like 4 years ago. And even from then, just like how things have changed and new information. And so now you've put the fear of God into me, and I'm going to be definitely buckling down on things.
Thanks, Brianne and Maria.
Jen, this is Terry. I wanted to add that I love the review. This is really good information. I've heard some of it before, but this is very detailed, and so I really appreciate the information that you provided. I'm looking forward to future trainings.
Great. Thanks, Teresa.
Mm-hmm.
Anyone else? David, are you still there? I think he's on mute. All right, well, I'm gonna give you guys back to your day, and you guys will start seeing a new, we'll set up a new time to do this second installment. I really appreciate you guys taking the 2 hours to go through this really exciting topic of compliance. So I appreciate you guys sitting through that, and reach out to me if you have any questions. If you need a certificate of attendance, please let me know and I'll draft one up for you guys.
Thanks so much, Jen.
Jen, I have a quick question. Is this recording going to be available for review at all?
Yeah, I think it's okay enough that I'll release it for viewing.
Okay.
Yeah, for sure.
Okay, thank you.